I feel guilty to consider GLP-1 injections. Is Ozempic a fad just created by Hollywood? Dr. Makhija, I've tried everything for the last few years, exercise, dieting. Does it mean I failed and I don't have any willpower if I'm taking GLP-1? Dr. Makhija, I see everyone on Ozempic. Is it a miracle drug? Can I just take it for a few months and then stop it and accomplish that weight loss? The Ozempic face and Ozempic butt. Many of my patients do get afraid of that. Doc, do you think if I go on this medication, I will have that same butt and face, which I don't want? These and so many more questions for GLP-1 injectables, especially in this era where we have TikTok, influencers, social media, lots of health gurus, or even, your celebrities talking about these medications. So let's look at fact. What is the science behind it? And is it really needed for everyone? Does it need to be in water? Let's break down the concept of science. How did we get to GLP-1? And what are the medical indications? And let's answer your questions. All right, this is Dr. Makhija on our podcast show, Hormones and Hope. This is part 2. So if you haven't watched or heard or tuned in into our previous episode, which talks about 5 solutions or strategies to help you transform your health before we look at medications, go tune into that episode. It's a short one, and then we will dive into GLP-1 medications. So let's look at it one by one. Now, what is GLP-1? Some call it as GPL-1, GLP-1, but it's glucagon-like peptide 1. And we also have something called as dual-agonist, which is GLP-1, and GIP, which is the gastrointestinal peptide. Now, what am I talking about? So glucagon-like peptide and glucagon-dependent insulinotropic polypeptide, which is GIP. Now, these are natural hormones that your body is already making in your gut, in your intestines. And these are usually released after you've had food. And they also help to release appropriate insulin, which is also a hormone from your pancreas, and help with regulation of blood sugar, appetite regulation, as well as your digestion. So we know about these hormones, and the medications mimicking these hormones were first FDA approved in 2005, and the name of the compound was called exenatide by Dow. So as endocrinologists, we were amongst the first specialty who were using GLP-1 for an FDA-approved indication for treatment of type 2 diabetes mellitus in 2005. So my friends, patients, community people who are hearing this or watching it on YouTube, remember, it's not an experimentation. You're not a guinea pig if you're thinking about considering these medications for your medical condition, or if you've had a discussion with your healthcare professional, with your physician about these medications. We've had them since 2005. Now we are in 2025 while we're recording this episode. So since those last few decades, we've had quite a lot of development in science. And more commonly, now you're hearing about semaglutide versions, which is Ozempic and Wegovy, and the tirzepatide, which is a dual glucagon receptor agonist, and that is Mounjaro and Zepbound. There are a lot of studies coming along, probably getting published in 2026, and further other better versions of these molecules, which also could potentially be FDA approved for other medical conditions as we learn more about it. So keep listening and I will share more details. So let's see what happened since 2005. Now, in 2005, it got FDA approved for type 2 diabetes. And gradually, as we were looking at the improvement in blood sugar levels, there was also profound change in the weight. And as clinical trials were being conducted, these same medications got also an FDA approval for obesity management, obesity treatment. Now, obesity does not mean that someone's fat, right? Obesity is an actual chronic disorder, and it has a lot of biological changes or pathophysiological changes. That is, your body works in sync. And if that's being disrupted, like how the cross signaling is occurring, that's looking at the pathogenesis. and we have multiple pathways which are affected, which are not in harmony, leading to obesity. So, obesity is a chronic disease. It is defined as the epidemic of this era, a medical condition. And what you want to understand that it is not the lack of willpower. It is not purely avoiding good nutrition and exercise, which leads to obesity. Now, yes, those were common causes or etiologies that we've had, and we definitely need to hone our lifestyle changes. But the reason I'm here today talking about medications is also to help you understand that when we have pharmacological management available, and if an individual is dealing with a disorder which is leading to further complications, it is good to have an open mind, understanding the pros and cons of what's out there in the pharmacological world, in the world of science. And then you can make a right decision that is this medication for me or is it not for me? And have a good discussion with your prescribing physician or your healthcare professional. So, my goal today, as well as in this podcast, is to break down the science and complement it with wellness, with lifestyle. So we don't lose the support of lifestyle as we are talking about medications, which is GLP-1 or dual-agonist GLP-1 and GIP. Okay, so what are these medications and what are the FDA-approved indications? To date, this podcast is being recorded in November of 2025. And to date, we have FDA approval for type 2 diabetes mellitus, for obesity management, for recent approval for obstructive sleep apnea, specifically only for tirzepatide, which is Zepbound as the brand name, and metabolic associated steatohepatitis, which is previously known as fatty liver disease, where semaglutide, Wegovy, has been FDA approved for the same thing. So now, other than endocrinology, we have primary care physicians, we have obesity medicine specialists, we have gastroenterologists, we have cardiologists who have been able to prescribe these medications to improve the patient health outcomes, to reduce the risk of complications that come along with two medical conditions, which is type 2 diabetes and obesity, and also help us tackle with the root cause, which is insulin resistance. So, to break it down again and to help you debunk some myths, here are a few things. When today I'm talking about GLP-1, GIP medications or dual agonist, I'm specifically talking about the ones which were used in clinical trials and which are FDA approved. I am not giving any information or recommendations for the compounded versions, which are available in many spas, wellness centers, health centers, as well as many physicians prescribing it. Personally, I practice evidence-based science, and until unless I don't have enough data to support this for my patient use, what you're hearing is just the FDA approval indications for FDA approved medications, which are available in prescription forms. And all these medications are self-injectable. Okay, let's come back now. So GLP-1, semaglutide. Semaglutide in the FDA approval form is Wegovy and Ozempic. So Ozempic has been used for such a long time for treatment of type 2 diabetes. Yes, the media, the celebrities have brought this out in the last few years in terms of revealing and sharing that they've been using it. But I want you to know that we've had these medications for a long time. So it's not something that is out in the market recently and everyone is trying to just experiment. But in the field of medicine, it is a legit prescription with legit outcomes for type 2 diabetes, with improvement in their A1C, with reduction in their complications associated with type 2 diabetes mellitus. Now, Wegovy is the same compound, which is semaglutide, manufactured by the same company, is FDA approved for treatment of obesity. Now, there are other indications because right now obesity is categorized based on body mass index, that's BMI. We do have indications where if someone's BMI is greater than 30, then these medications are FDA approved for those reasons. But if someone has BMI of 27 or greater and they have other metabolic comorbidities like prediabetes or hypertension or high cholesterol, then your physician and you can discuss about this medication and learn if that is going to be a good choice for you or not. Now, what is also important to know that we have FDA approved indications, but the insurance world, that is the health insurance world, speaks a very different language. So don't be surprised. And this, I specifically educate my patient that you meet the FDA approved criteria medically in the field of science, but your insurance makes their own, your health insurance makes their own criteria. So many times when I prescribe these medications for a very legit indication, the insurance will deny it that the patient's BMI should be 40 or greater to have them approve this medication, which is absolutely BS, because if someone's BMI is 35 or 39.8, they are denying it. So that's where I don't have any control. Patient doesn't have any control on getting the right medication for the right medical indication so that their medical disorder like type 2 diabetes or obesity is actually getting better and they have lesser complications. It just gets out of our control. Now, to tackle that, these companies have made all these medications available for cash price. Now, absolutely, these are still insanely expensive, which comes to a cost of around average $400 to $500 a month. But there is an option for patients who get completely denied to have these resources, and there has been a lot of advocacy to reduce the cost of GLP-1 medications so that the patients who actually meet the medical criteria have access to it and it's affordable. So now you know the nuances, or I would say certain nuances that physicians, endocrinologists, and patients have to deal with. Now, how do you know that if it's a right medication for you or not? So I'll tell you an example. My recent last week clinic had a young gentleman, 32 years of age, or he was just going to turn 32. He was here with his wife, and I've seen him 3 times in the last 2 years, and it's usually for a second opinion. So initially, he was dealing with type 2 diabetes mellitus, diagnosed in early age, and there is also a contribution from his ethnicity, which is Middle Eastern. And he has been very diligent in focusing on his lifestyle changes consistently. And this I can vouch for because I have known him for such a long time now. But once he gets his labs, he's usually coming back to me just for a second opinion as to what are the lifestyle interventions he could do. And he really doesn't want medication. His PCP had prescribed him metformin, but he reported that, I just take it on and off. Now, I would have suggested him to use a continuous glucose monitor, which I always do because that really gives an idea of the data of glucose levels 24/7 rather than just relying on A1C. But he did not seem to be interested in using a CGM for a longer term. But he was able to bring his control between 6.5 to 7%. I usually aim a lower A1C or almost normal for such young individuals and work towards that goal. Anyway, so I see him once in 2024, and then he comes back in 2025 for another reason. And this time he says, my type 2 diabetes is pretty well controlled. I'm, working on my lifestyle interventions consistently. But now my testosterone levels are either lowish or low normal. And that's usually 250 to 300 in that lab range. And I had him tested first thing in the morning, and the same values as pituitary levels of LH and FSH, which are very much needed to look at when you're assessing the testosterone levels, were also appearing to be normal. So that is something called a secondary hypogonadism, which I can cover in another episode. But the point is, his BMI was getting close to 38. He complained inability to lose weight despite trying low-caloric diet, significantly in tune with his exercise routine and gym workouts, inability to gain muscle, but he felt strong. The other symptom that he had was, I just feel tired all the time. I had him get a sleep study, and of course, through his insurance, it took a while for him to get the sleep study. And yesterday, I saw him back. Sleep study showed moderate sleep apnea. The reason I suggested sleep study was not just related to his fatigue, But someone with secondary hypogonadism, that is low testosterone, and the LH, FSH, pituitary signals are also suggesting that type 2 diabetes, obesity, and the sense of fatigue, I would definitely recommend to get a sleep study done or a sleep assessment done. A home sleep study is a very simple test that can be done and easier to get approved rather than going into a sleep center and spending time or the 24 hours or your sleep or your nighttime in that sleep center. So anyway, moderate sleep apnea, obstructive sleep apnea was suggested to go on CPAP. His blood sugar control average is still around 6.57%. Further weight gain, his BMI was almost 39.8, 39.9. And he also had a history of fatty liver disease based on his liver enzymes, which tend to be mildly elevated in periodic lab testing, right? We have almost every indication for GLP-1 here. And he has really been in tuned with his lifestyle interventions. Where was the gap? It was the education. He had looked through so many influencers that, will I get an Ozempic? But, does that mean that I have no willpower if I go on GLP-1? Does that mean that I have to be on this medication lifelong? Does that mean that I'm going to get addicted to this medication? What about that weight loss? Like, will I become too skinny? Or can I just keep my good weight and just shut off the bad weight? Will this suddenly improve my testosterone levels? Will I not need the CPAP if I go on GLP-1? So many questions, and they're very legit questions. I'm pretty sure many of you might relate with this patient, or you may have heard this story, or if you have any male in your life, they might be going through this. But this patient is just 32. Yes, you do commonly see this presentation in midlife for men, but early onset. I know that he can benefit so much. Yes, with lifestyle, we can even hone the lifestyle further, but how much can he benefit from the right pharmacological medications? So how do we start? Where do we initiate the conversation? So that's where this science-based answers, looking to the right resources, become very important. Now, why are we worried about obesity? So just to give you stats, today I had a lecture for CGM and lifestyle medicine by Fresno Madera Medical Society at our medical school campus in Clovis, California. And I was just sharing the stats for type 2 diabetes. 50% of adults in US, in the United States of America, have either pre-diabetes or type 2 diabetes. That's insane. The percentage of type 1 diabetes is the lowest, but it's pre-diabetes, type 2 diabetes, and type 1 diabetes. So 1 in 3 adults have pre-diabetes. Imagine that, your primary care clinic, your family medicine clinic, most of the patient population are dealing with these medical conditions, or they may be dealing with obesity, or they may be encountering these other metabolic disorders. I haven't even touched based on hypertension, hyperlipidemia, heart disease, because all the root cause is also contributed by that insulin resistance, right? So these medications, the way they're working is, number one, they are telling your body, right, and that is specifically your stomach, that, hey, the way you contract, can you just slow the speed down? So imagine if your stomach is a blender and it blends at a particular speed. It's just turning the notch down a little so that whenever you eat, there is a sense of fullness. And there is a sense of fullness, there are signals sent to your brain for appetite. I'm full, I don't feel like having anything. More and more we know about these drugs, they also alter the cravings, and that's why it's also being studied in patients who have alcohol addiction to see if that would be beneficial in these scenarios to help them avoid that addiction. The other thing that it does is, like I said earlier, is it helps to release insulin from the pancreas after you've started eating. So that's another mechanism. It also helps with your digestive system, the way your entire gut is contracting. Now, there are common side effects that we've seen, and that is usually gut related. So, initial diarrhea, not everyone will encounter that, but I usually counsel my patients on that. Loose stools when you start these injectables. Constipation is notoriously common, but we have simple tips and tools. So, what I do, and that's my clinical tip, that If someone's dealing with constipation even before starting GLP-1, well, let's fix the constipation. It doesn't take too long. It's a lot of regular remedies, that is talking about fiber. Can you add some more fruits, yeah, your legumes, complex whole carbs, grains, as well as my simple tricks are chia seeds, flax, and if you're okay with hemp seeds, that would also be a great source of fiber and gives you extra source of protein and antioxidants. To start with that, like let's bring about that transit time, change that so that you're getting regular bowel movements. And if that's fixable in next few weeks, and then we can initiate the GLP-1. In patients who have other symptoms or hemorrhoids, or there seems to be, a organic cause, then of course a gastroenterology consultation would be beneficial. So constipation, you also have over-the-counter remedies, magnesium supplements, Metamucil, Miralax, fiber gummies are also very helpful. I try to refrain from using Dulcolax or Senna periodically unless someone really needs it. But usually, 99% of times, patients benefit with this strategy while we're also incorporating a lot of nutritional additions, changes for their fiber intake. The next one, the common one, of course, is nausea, which is also gut related, right? So if there is a sense of fullness, patients usually have this sense of, you know what, I don't feel like eating anything, or there's this sense of nausea, but you're really not vomiting. We barely see vomiting unless there's a rapid increase in the dose or someone is very, very sensitive to these medications at the start. Most of the times, these symptoms of nausea may subside and would be transient the first few weeks. Or patients have learned this pattern that I will inject it on Friday. I know Saturday I may not eat much. And, I will probably just take it easy, rest, and make my routine accordingly. And that works with their schedule without any issues or problems. Now, the appetite has changed, right? So there is a change in appetite, where the side effect I would call as concerning would be complete loss of appetite, where you're not eating anything. And that's where, the education, the discussion with my patients is so crucial, that our goal is not to just not eat anything, right? So the titration of the doses can be slow for GLP-1 medications. I let my patients decide and tell me that, okay, I'm ready for the next step up, while they're aggressively working on their discipline, journaling, their mindset with me, coaching about, okay, what's ideal for me? What's budget friendly nutrition for me? I'm busy, I'm an executive, I have lots of meetings, I have kids. So, how can we tweak that nutrition, as well as, of course, your strength training, your exercises, your walks, which is, by the way, going to avoid having that Ozempic butt, what people call about, right? Because gradually you will see the fat loss, and that is usually visceral fat as well. The bad fat, again, tune in to my previous episode where I talk about the visceral fat and the subcutaneous fat and the body composition, so that you get an understanding of how GLP-1 can help. So your strength training, your exercise, getting a body composition is going to be essential while you're on GLP-1, because you're not just losing the weight to check it on the scale, but you're actually using this medication to gain health, to reduce your complications, right? To reduce your visceral fat, to improve your energy, to reduce your glucose levels, to reduce the inflammation that we have, to reduce the insulin resistance that we carry all the time with that visceral fat. So when when you're very clear with the goals, then you can actually think about having a discussion for these medications with your primary care physician, healthcare professionals, and endocrinologists. But trust me, even in clinical trials, they didn't give up on lifestyle interventions. When you integrate both of these, you can maximize the benefits. Now, the weight loss range is also very crucial to understand. So I'll give you some data into how these medications have shown to improve the changes in the weight. So usually, ideally, there is this range from almost 13% to almost 22% of weight change through a span of treatment. So when patients are on GLP-1 injectables for this specific disorder, there is, we have data almost until 4 to 5 years consistently showing consistent, sustainable changes. And remember, when our weight has improved, when our visceral fat has lowered, when our blood sugars are better, it doesn't mean that all the complications will also dramatically reduce only for that period. We are building some legacy here, right? So the more sustainable effects we have, the longer reduction in your complications. What do I mean by that? So this answers one of the questions that was at the beginning of our podcast, that can I just be on this for 2 to 3 months, have the weight loss and then just stop the medication? Knowing that there is a possibility, a very high likely possibility of rebound weight gain if you just abruptly stop it. Now, when our medical FDA approved indications are, they're for ongoing treatment for type 2 diabetes, for obesity management. In my clinical practice, if patients are on these medications, now I'm specifically focusing on obesity as a disorder or increased visceral fat, or there are a lot of symptoms and features of metabolic syndrome, and we have the GLP-1 as an option. Again, I don't leave lifestyle interventions for our patients. Then I do give them a goal that let's consider this medication, say, for a span of 1 year. But in that 1 year, we want to make our life very disciplined. I'm working with them on their nutrition. I'm working with them on figuring out that how can you just improve your body composition, right? And if there is a chance, we can look at reducing your doses and reassessing that. Is there a rebound weight gain? What's happening to your visceral fat? Are you still consistent with your exercise and you're not losing muscle? And that gives us a very higher likelihood of weaning off to discontinuing these medications without much of a rebound or complete rebound weight gain. Of course, there may be a 5 to 7 pound weight shift upon the discontinuation of this medication. Now, the reason I can say this confidently is in our patients who are planning to conceive. So, our women who have inability to conceive, or if they're going through an embryo transfer, IVF, and they either have type 2 diabetes mellitus or obesity, and they need to get to a certain parameter to reduce their risk of complications during these or before these procedures. So we have to wean them off before they go for an embryo transfer, before they conceive, or before they're going through IVF or IUI. And, usually that's the usual protocol. And it's amazing that they are able to go for successful procedures and have conceived successfully. And other than the pregnancy weight gain, they're not gaining profound weight as they would have in the past based on their baseline weight. So it's all about also education. Like, what's right for me? How can I gain more control on my health once I'm using these medications? But for other scenarios, if you're dealing with type 2 diabetes mellitus, and if it's progressive, if you're dealing with severe obesity, morbid obesity, it is very essential to think about this as a long term, unless, there is this very small percentage where your biology has shifted, and if you were ever to wean off, there is not much of a drastic change. But we just lack that evidence right now in science that here is a clinical trial, patients tried this medication, GLP-1, and they were on it for a couple of years, and then they were weaned down or weaned off, and they discontinued it, and we either had some amount of weight gain or no amount of weight gain. But very commonly in clinical practice, I see patients who've used it by other medical providers, and then patients decided to stop it. Within a year, I see that they're back to their baseline weight, right? So having this complete understanding, you're understanding these medications, you're understanding science. I tried to simplify it as much as possible for you rather than adding a lot of medical jargon as to how do you approach these medications. Now, just for your understanding, we will link in the handout for GLP-1 in our podcast as well as on our YouTube, or you can go to my Instagram link tree where you can download the free guide. If you're watching this on YouTube, I'm actually holding our GLP-1 handout, which is a 4-page, which talks about the most recent FDA-approved ones. What are the side effects? I also talk about hair loss, other vitamin supplements, how to deal with constipation, gastroesophageal reflux, because I didn't cover all the side effects, as well as, what can you do for your lifestyle and small changes, and how can you get your body composition, which I also talk about in my previous podcast. So take a look, find these right resources. I would highly, highly recommend that. Follow the right physician experts or look for obesity medicine specialists, look for endocrinologist because we've been prescribing GLP-1 for the longest time, and also see that who can help me integrate both of these, right? So integrating lifestyle interventions and the medications when needed. And how can someone help me with that coaching? We all need coaching, right? I, being a physician entrepreneur, I have done, business coaching so that it helped me with a lot of mindset change with, what is the positive outlook? What is the perspective of being a physician entrepreneur and always being in the seat of giving? So I've learned massively by for these coaching. Like just giving you an example, if you have kids, how much do you try to get the right math coaching, the right tennis coaching, the right basketball coaching so that they could improve? Similarly, for your health, if you're struggling, don't hesitate. See for a physician expert who is also providing the coach or who works with a health coach. I personally do my coaching with my patients, and also my goal is to have a group coaching program for individuals. And even if they're not getting prescriptions from me or are not under my medical care, to have that lifestyle coaching or an education, everything about endocrinology and hormones available for anyone in this world. Well, I'm just releasing some surprises for you for 2026. But thank you so much for listening to this episode. Tune in again as I will be interviewing a lot more obesity medicine physicians in the next few weeks so that you also get perspectives from other prescribing physicians, other physician experts in this realm. And I can help you as much as I could to give you the right evidence-based science knowledge, as well as tips and strategies to work on your health and your health transformation. Until the next episode, this is Dr. Makhija signing off. Stay well, stay happy, and tune into the right resources. See you next time.